outcomes. Since the coining of the term pharmaceutical care in 1990, pharmacists in all settings have taken on greater responsibility for patient outcomes. Several terms have been used to describe the pharmacist's non-dispensary role in patient care: clinical or cognitive services, pharmaceutical care, and now medication therapy management, MTM. Regardless of the term used or the setting in which care is provided, pharmacy practice should be proactive and patient-centric to ensure quality patient care. B. Definition. In 2005, a definition for MTM was reached by consensus among 11 national pharmacy organizations to, essentially, medication therapy management services, MTMs, are a broad range of patient-specific services designed to improve quality of care and continuity of care, as well as optimize treatment outcomes. C. Medicare Part D and MTM. In 2006, the Medicare Modernization Act, MMA, of 2033 was implemented, providing prescription drug coverage, Part D. The MMA has additional historical significance in that MTM was mandated for eligible Medicare beneficiaries. Medicare Part D services are provided by privatized prescription drug plans, PDPs. The Centers for Medicare AMP, Medicaid Services, CMS, are responsible for requirements and regulation. 1. Eligibility. Although in practice MTMs encompasses a broad range of services that can benefit any patient. Under Part D, only patients who meet the following specific requirements are eligible for MTM. A. Multiple chronic conditions. B. Multiple Part D medications. C. Anticipated Part D medication costs of $4,000 per year. 2. CMS allows the PDPS to set their own criteria for what constitutes multiple. 3. CMS allows the PDPs to determine how MTM will be or can be provided, and includes the following: A. Patient mailings. B. Call centers. C. Pharmacist-provided MTM. 4. Under Part D, when the provision of MTM is allowed by the PDP to be done by a patient's pharmacist, the PDP typically pushes the case to the pharmacy. MTMs provided to a Medicare patient prior to the push, that is, a pull case, are typically not covered under Part D, and therefore payment by the PDP for services rendered may not occur. Second scope of medication therapy management services. A. Separation of MTM from dispensing. 1. MTMs are provided by pharmacists in several settings. MTMs are distinctive and separate from dispensing services. Pharmacists may, at the time of dispensing, identify patients who would benefit from MTM. However, MTM is more in-depth than traditional medication counseling. 60 Medication Therapy Management. Penny S. Shelton K. Page D. Brown. Medication Therapy Management 1181. Mandated by Omnibus Budget Reconciliation Act of 1990, OBRA 90. MTM is more holistic, generally encompassing the patient's entire medication regimen in the context of prevention, treatment, and management of conditions and disease states. B. Protection of patient information. 1. The provision of MTMs that includes patient interaction, documentation, and billing should ensure patient confidentiality and be compliant with the Health Insurance Portability AMP, Accountability Act, HIPAA. C. Comprehensive versus focused MTMs. 1. A pharmacist can design his or her practice to provide several MTMs, including comprehensive medication therapy reviews, NTRS, specific disease state management programs, and/or targeted interventions. For example, a pharmacist may identify via the provision of a comprehensive MTR that his or her patient needs additional care for his or her diabetes, that is, disease management, or perhaps needs strategies to improve adherence, that is, targeted intervention. 2. Pharmacists providing disease state management services or targeted intervention programs can design their practice to include point-of-care laboratory assessment, cognitive services, product lines, and patient education. Examples of pharmacist-provided MTMs in various healthcare settings include, but are not limited to the following: A. Diabetes; B. Anticoagulation; C. Hypertension or hyperlipidemia; D. Adherence. 3. Regardless of whether the service is comprehensive or focused, all MTMs involve patient interaction and participation to optimize therapeutic outcomes. D. Patients who may benefit from MTMS. 1. Complex pharmacotherapy patients. A. Multiple medications. B. Multiple disease states or conditions. C. Narrow therapeutic index medications. D. Medications requiring laboratory monitoring. 2. High risk for loss of continuity of care. A. Multiple prescribers. B. Recent transitions of care, for example, hospital discharge, rehabilitation, skilled nursing facility discharge. 3. Evidence of or high risk for. Medication non-adherence. A. Irregular refill history. B. History of failure to pick up new prescriptions. C. Stockpiling or incorrect pill counts. D. Financial burden, for example, uninsured or underinsured. E. Low health literacy. F. Poor transportation. G. Patient's beliefs indicate resistance to treatment. 4. High-cost regimens. 5. Noticeable decline in the patient's health or functionality. Third, essential components of medication therapy management. A. Patient and pharmacist relationship. 1. Pharmacists have historically been viewed as one of the most trusted professionals based on Gallup's annual Honesty and Ethics survey. 4. Pharmacists are also one of the most accessible healthcare professionals. Patients express greater satisfaction with care when they perceive quality interactions with a healthcare provider. 2. The provision of face-to-face MTMs strengthens the patient-pharmacist relationship. Although some MTMs can be provided via a phone interaction, face-to-face interaction with the pharmacist affords the ability for the pharmacist to observe visual signs and symptoms, as well as changes in the patient's status and well-being. 1182, Chapter 60, the third. 3. For optimum patient care to occur, pharmacists need to be culturally competent and aware of the patient's level of health literacy. A. Cultural competency means the pharmacists are cognizant of their patient's diversity regarding beliefs, values, behaviors, and language. Barriers in these areas can lead to miscommunication and poor health outcomes. B. Health literacy is an individual's ability to obtain, understand, and follow directions related to his or her health care. According to the U.S. Department of Education, 9 out of 10 Americans have limitations regarding health literacy. 5 patients with poor health literacy generally have poor health status and are more likely to have medication-related problems. The Rapid Estimate of Adult Literacy in Medicine, revised, RELMAR, is a simple and quick tool that pharmacists can use to assess patients' health literacy. 6. Pharmacists need to adapt their counseling and MTMs based on the patient's health literacy level. 4. Successful MTM requires patient participation. Many MTM-related interventions require lifestyle or behavioral changes. Pharmacists need to assess their patients' willingness to participate in change. Pharmacists should know the stages of change delineated within the trans-theoretical model of behavior change, Table 60-1. Pharmacists can also use a 0-10 visual analog scale for assessing a patient's willingness to change. Scores $5 suggest the patient is willing to change and should be supported and encouraged. 8. Table 60-1 example application of trans-theoretical model of stages of changes even. Stage definition example application, self-monitoring glucose. Pre-contemplation patient has no interest in changing behavior or sees no need to change. Patient discharged from hospital. Prescriptions for an oral anti-diabetic agent and a glucose meter are called into pharmacy. Patient picks up oral agent but refuses the meter and states, "I'm not going to check my blood sugar. I'm not sticking myself. It's unnecessary. I don't have diabetes." Relapse, bidirectional, movement, between, stages, occurs. Contemplation patient is beginning to weigh pros and cons of change and is considering changing his or her behavior but is still somewhat ambivalent. Patient is discharged from hospital. Prescriptions for an oral anti-diabetic agent and a glucose meter are called into pharmacy. Patient picks up oral agent and the glucose meter. She indicates at the time of purchase that she understands the importance of monitoring but refused a meter teaching session with the pharmacist. 3 days later, the pharmacist calls to follow up with the patient and the patient states that she has not used the meter or taken it out of the box. Preparation patient is taking action or shows signs of preparing to change. Patient is discharged from hospital. Prescriptions for an oral anti-diabetic agent and a glucose meter are called into pharmacy. Patient pays for both and asks for the pharmacist to explain how to use the meter. She conducts her first finger stick in the pharmacy and asks for a follow-up appointment to meet with the pharmacist to talk about diabetes and diet. Action patient has implemented change. Scenario is the same as in the aforementioned. Preparation. And when the pharmacist calls to check on the patient, she provides the pharmacist with values for twice daily blood glucose. The pharmacist confirms the date for her follow-up appointment and tells her that she is doing a great job with monitoring and that her blood glucose values are getting better. Maintenance patient is able to maintain positive changed behavior. Patient comes in monthly for medication refills, glucose strips, and lancets. Patient maintains a log of blood glucose values and has kept follow-up appointments with physician and pharmacist. Patient has started and adheres to a regular exercise routine and a low-carbohydrate diet. B. Patient caregiver interview. Depending on the patient, it may be appropriate for the pharmacist to include a caregiver in the patient interview. 1. Interview setting. A semi-private or private area is required for the provision of MTMs. For interviewing purposes, the more private the area, the fewer interruptions and the more likely the patient will share and retain pertinent information. B. The interview area should have adequate lighting and a comfortable temperature. The space should be equipped with a table and chairs. The chair for patients should have arms to assist the patient in lowering to and rising from a seated position. The space should be large enough to accommodate the pharmacist, patient, and possible caregiver. In addition, the space should be readily accessible to patients with mobility problems, for example, wheelchair, walker. C. The space should be relatively quiet to facilitate conversation, for example, ability to close a door to the space, no ringing phone. Many MTM patients are elderly and have hearing deficits. Failure to create an environment where background noise is minimized may escalate patients' frustration in communicating and adversely affect the desired outcomes. 2. Essential technique A. Use open and honest communication. 1. Introduce yourself. 2. Explain the purpose and process of the MTM session. Ask for the patient's expectations, concerns, and/or issues to be addressed. B. Avoid using and be aware of patients' incongruent body language, that is, mismatch in verbal and nonverbal language. C. Maintain good eye contact throughout the interview. D. Conduct the patient interview at the patient level. Avoid medical jargon. E. Ask purposeful questions. F. Use a combination of open and closed-ended questions. Open-ended questions cannot be answered with a simple yes or no, and generally begin with who, what, when, or how. G. Avoid rapid-fire questioning. Allow the patient time to answer a question before posing a second question. H. Avoid leading questions. For example, you take your cholesterol medicine at night, right? I. Use probing questions. Example. Questions asked to help elicit specific information from the patients regarding their medication therapy needs and problems. J. Use non-defensive phrasing. For example, patients may become defensive with why questions. Instead of asking, "Why did you not take your blood sugar medicine?" ask, "What caused you to not take your blood sugar medicine?" K. Use active listening skills, Table 60-2. L. Communication strategies for patients with disabilities. Patients with disabilities are capable of patient-centric care and should be empowered to be active participants. 1. For patients with hearing deficits, remember to use a lower tone of voice and slower rate of speech. Use simpler sentences and sit directly across from the patient to facilitate lip reading. Verbal education should be augmented with written materials. Consider providing and making available to your patient a sound amplifier. 2. For patients with visual deficits, for example, presbyopia, cataracts, glaucoma, macular degeneration, color blindness, clear and concise verbal communication becomes critical. When written communication or materials are necessary, these should be printed on non-glare, off-white, or pastel-colored paper. The font should be 14 points or greater in size, and avoid the use of yellow, green, and red. 3. For patients with mental or cognitive deficits, the interview and education sessions may likely require the presence of a caregiver. Remember to always address the patient. Provide simple communication. Augment with simple written material. 3. Essential components. The content gathered during a patient interview is essential to enable a comprehensive assessment. The outcome of MTMs depends on the quality of information and data that pharmacist has available. It takes a considerable amount of time to do a thorough patient interview as indicated by the following components. 9. To improve efficiency, the pharmacist may. Medication therapy management, 1183. Have the patient complete or provide information in advance or train a technician to assist with data collection. A. Basic patient demographics, for example, name, date of birth, address. B. Chief complaint or reason for evaluation. In addition, it is helpful to ascertain what the patient caregiver wishes to accomplish by the MTMs. In other words, what are the patient caregiver's expectations? C. Healthcare priority, comfort, cost, or convenience. D. Past medical history, including surgeries and procedures, as well as any recent hospitalizations or emergency department visits. E. Preventative health information such as immunizations and health screenings, for example, colonoscopy, pap smear, mammogram, prostate examination. Table 60-2 Use of active listening skills in the patient interview. Active listening skill explanation application example. Facilitation. The interviewer uses words, body, language, and/or posture to encourage the patient to continue. Patient: I just haven't been feeling well lately. Pharmacist: while maintaining eye contact and leaning in toward the patient, tell me more. Interpretation. The interviewer deduces there is a problem based on a statement or statements and asks the patient to address the finding. Pharmacist: I noticed that you have asked some questions about memory today. Do you have concerns about your memory? Reflection. The interviewer checks his or her understanding of what the patient has said by repeating back a statement or statements in the patient's words and gauges the patient's response. Patient: and my doctor told me to start taking 12 tablets for my cholesterol. Pharmacist: your doctor told you to take a 12 tablet. Patient: yes. Clarification. The interviewer asks for more detail when he or she does not fully understand what the patient has said or implied. Pharmacist: you said you only take your naproxen when you need it. How often do you have to take it? Patient: not often. Pharmacist. How many times a week do you have to take it? Empathy. The interviewer recognizes the patient's feelings. Patient. I was in so much pain. I thought I was going to die. Pharmacist. That must have been very difficult and scary for you. How is your pain today? Confrontation. The interviewer uses an observation, a patient behavior, or an aspect of the interview to engage the patient in addressing a problem or situation. Situation. The patient's self-monitored. Blood glucose values have been consistently high. Pharmacist notices in the patient's shopping cart several food items that are high in sugar carbohydrate. Pharmacist begins confronting the patient with, have you ever had any diet education for your diabetes? Silence can be used in two ways. 1. Remaining silent after posing a question to enable the patient time to gather his or her thoughts and answer. And 2. Remaining silent after a patient's statement can at times be used to prompt the patient to share more detail. Patient. My daughter took me to the emergency room last month. Pharmacist maintains eye contact and remains silent, encouraging the patient to continue. Patient. They admitted me for pneumonia. 1184. Chapter 63. B. F. Family history. G. Social history that includes caffeine, nicotine, alcohol, prescription or illicit drug abuse, exercise, diet, occupation, and support network. H. Allergies. I. Medication history. Prescription, over-the-counter, herbal, and home remedies. 1. Medication name and strength. 2. Dose and directions, as labeled against how taken, for as-needed medications, PRN. Frequency of use and when last dose occurred. 3. Indication, or duration. 5. Perceived efficacy and side effects. If there are reported problems with efficacy or side effects, it may be helpful to inquire about other medications that have been previously tried and failed. 6. Prescriber. Thermos. 7. Pharmacy that filled the medication if not filled by interviewing pharmacist. Pharmacy. Date last refilled. Consider a pill count to help with measuring adherence. 9. Recent changes. Medications added or discontinued and/or dosage changes. J. Vitals and lab values. 1. Review of the patient's medication list prior to the appointment may be helpful to pinpoint and request the patient bring certain lab values to his or her appointment. Or 2. Consider having the patient sign a medical release during the appointment to enable the pharmacist to obtain lab values from the patient's physician. K. Review of systems. The pharmacist may be the first professional to detect a health problem for which a referral may be necessary. In addition, a generalized review of systems reveals problems or conditions not commonly reported in a medical history, such as falls, incontinence, and constipation. A review of systems may detect side effects that the patient did not realize may be associated with his or her medications, for example, dry mouth. L. Contact information for all prescribers and insurance information, for example, Medicare Part D PDP. C. Medication Therapy Review, MTR. The MTR is conducted to determine appropriateness of therapy. The pharmacist should concentrate on necessity, safety, and efficacy of therapy. A useful outcome of the MTR is the creation of a problem list, that is, medication-related problems. 1. Basic components of an MTR can be found within the Medication Appropriateness Index, 10, which helps to provide a systematic approach to the MTR. A. Is there a justification indication for the medication? B. Is there any allergy or contraindication for the medication? C. Is the medication or regimen being used the most efficacious? D. Is the dose, age, or condition appropriate? E. Are the directions optimized? F. Are necessary monitoring parameters practices in place? G. Is the duration of use appropriate? H. Are there any therapeutic duplications? I. Are there any drug-drug interactions, drug-food, Drug disease. J. Are there more cost-effective therapies available? K. Is the patient adherent with therapy? L. Are there any untreated conditions? D. Therapeutic planning. The problem list created from your systematic MTR is used to create a therapeutic plan. 1. The plan should be patient-centric, and with MTM for Medicare Part D, the plan is referred to as the Medication Action Plan. 2. The therapeutic plan is designed to prevent, alleviate, and eliminate medication-related problems. 3. The plan should be written to serve as documentation for services provided. 4. Pharmacists may choose to use a traditional SOAP or FARM format for their documentation. Table 60-3. 5. Ideally, therapeutic plans should include the following. A. Goals for therapy. B. The patient's status on desired outcomes medication. Therapy management 1185. 1186, Chapter 60, the third. D. C. Recommendations for intervention. D. Recommended monitoring parameters. E. Desired time frame for follow-up. F. Contingency plans for treatment may also be included in the event that treatment goals are not reached. 6. Without appropriate follow-up, even the best of therapeutic plans are likely to fail. The success of therapeutic plans also depends on patient adherence, which is why this process should be patient-centric. 7. The therapeutic plan required for Medicare Part D beneficiaries, that is, MAP, should be developed in collaboration with the patient and should contain action items for which the patient is responsible. E. Patient Medication Record, PMR. After a comprehensive MTM, patients should be provided with PMR containing list of all of their medications, doses, directions, indications, any precautions, and start-stop dates. The patients should be instructed to present their PMR to all healthcare providers. The pharmacist should assist the patients in updating their PMR regularly and upon changes to the patient's regimen. F. Documentation is an essential function of the MTM process. The age-old adage, if it's not documented, then it wasn't done, remains true. 1. Pharmacists should maintain MTM files for their patients that include their interview notes, medication therapy review workup, the therapeutic plan, and follow-up care. In addition, separate paperwork may be needed and should be maintained for billing. 2. Since 2006, both pharmacies and pharmacists must have a National Provider Identifier Number, NPI, to bill for clinical services.
Siglo. Pharmacists can obtain their NPI numeral from the National
NPI from the National Plan and Provider Enumeration System at npps.cms.hhs.gov/nppes/welcome.do. 3. Current procedural technology, CPT, codes are commonly used for billing by healthcare professionals for patient care. There are 3 CPT codes for MTMs, Table 60-4. 11. These HIPAA-compliant codes may be used when billing third-party payers for services. However, the billing codes. Table 60-4 Current Procedural Technology, CPT codes for medication therapy management, MTM 11. Definition of CPT codes, 99,605 MTM service provided by pharmacist, individual, face-to-face with patient, initial 15 mins. With assessment, and intervention if provided. Initial 15 mins, new patient. 99,606 initial 15 mins, established patient. 99,607 each additional 15 mins, list separately in addition to code for the primary service. Use in conjunction with and farm note soap note findings, the subjective data, as and objective data, o assessment, a resolution, recommendation, MAR plan, b monitoring, m and follow-up. Table 6 demonstrates 3 components of a farm and soap note do not guarantee coverage and hence payment for services rendered. Therefore, patients need to be informed of the fees for MTMs prior to the provision of care. 4. For Medicare Part D, the MMA and CMS mandate that MTM be provided for eligible beneficiaries, but the decision for how MTM will be provided is left to the PDPs. Some Medicare Part D PDPs have contracted with specific MTM online services, such as Mirixa and Outcomes Pharmaceutical Healthcare. Pharmacists conducting MTM for beneficiaries of these PDPs must complete training on how to document and bill with these specific platforms. G. Medicare Part D core components for MTMs. Pharmacists may offer many services within the framework of the essential components noted earlier. MTM through Medicare Part D requires 5 core components, Table 60-512. Fourth references. 1. HEP core components. Medication Therapy Review, MTR Personal Medication Record, PMR Medication Action Plan, MAP Intervention and Referral Documentation and Follow-up Medication. Therapy Management 1187, 1188, Chapter 60. Choose the best answer for questions 1-5. 1. In the provision and billing of MTM services for a Medicare Part D patient, the pharmacist must complete: first, a comprehensive medication review. 2. A personal medication record. The third, a medication action plan. A. I only. B. The third, only. C. I and 2, only. D. DACU and the third, only. E. I, 2, and the third. 2. Mrs. Smith has recently been diagnosed with hypertension and hypercholesterolemia. She presents to your pharmacy today with new prescriptions for hydrochlorothiazide and simvastatin. When she picks up her medications, she asks to speak with the pharmacist. She asks several questions about her new regimen and inquires about how she can check her own blood pressure. According to the trans-theoretical model for behavioral change, what stage is Mrs. Smith? A. Pre-contemplation, B. Contemplation, or C. Preparation, D. Action, me maintenance. 3. Which of the following are forms of active listening interview techniques? I. Restoration. 2. Facilitation. The third, silence. A. I only. B. I and 2, only. C. I and the third, only. D. 2 and the third, only. E. I, 2 and the third. 4. The documentation of your recommendation for the patient to have a follow-up A1 Celsius obtained in 3 months should be noted in which section of a SOAP note? A. Subjective. B. Objective. C. Observations. D. Assessment. D. Plan. 5. Pharmacists who bill Medicare for MTM services must have a first pharmacist license. National Provider Identifier Number. Third, Medication Appropriateness Index Number. A. I only. B. I and DACU, only. C. I, the third, only. D. 2 and the third, only. E. I, 2 and the third, only. Study questions. 1. The answer is E, see third G, Table 6D-5. The provision of NTM for Medicare Part D must include the 5 core components of NTM. A. Comprehensive medication review, personal medication record for the patient, and a patient-centric medication action plan represent 3% of the 5 core components. The remaining 2 are intervention and referral and documentation and follow-up. 2. The answer is C, CIIIA, Table 6D-1. The patient is preparing to take action toward changing her personal care of her hypertension and hypercholesterolemia by seeking medical attention, picking up her new prescriptions, asking for information from the pharmacist, and showing interest in wanting to learn to self-monitor. This is the stage preparation instead of action because the patient has not yet implemented the changes in her personal care. Answers and explanation. 3. The answer is D, see third B2, Table 6D-2. Facilitation and silence are well-recognized methods of utilizing active listening within a patient interview. Restoration is not one of the active listening skills. The remaining active listening skills are interpretation, reflection, clarification, empathy, and confrontation. 4. The answer is E, see the third. Utilizing active listening within a patient interview. Restoration is not one of the active listening skills. The remaining active listening skills are interpretation, reflection, clarification, empathy, and confrontation. 4. The answer is E, see the third D4, Table 6D-3. When using a SOAP format for documentation, all recommendations, including follow-up lab work, should be noted in the Plan T section of the SOAP note. The sections of a SOAP note are subjective, objective, assessment, and plan. Observation is not a section. 5. The answer is B. D, the third F2. Since 2006, under the Medicare Modernization Act of 2000, Three, licensed pharmacists can bill for MTMs provided to patients. Pharmacists need a National Provider Identifier Number, NPI. Medicaid